Good afternoon, everyone. Thank you for joining today's webinar. This presentation is basically an expanded version of a poster that I presented at the Regional Symposium on Dissemination and Implementation that we had here in LA in March of this year. I will be presenting a version of what we did here in LA, where we got together the federal government, basically the VA, and the city and county of Los Angeles, along with the Los Angeles Homelessness Authority. I will go over that project, but what I'd like to do at first is to tell you a little bit, for those of you who are unfamiliar with the Veterans Affairs, I'd like to tell you a little bit about the research group that I'm with, which is QUERI, and then I'll go through some statistics on homelessness and HIV, and then I'll launch into the project, and then briefly at the end I'll talk about some future efforts that, that we're thinking about conducting. So first, sorry, we're having some trouble advancing. Great, thank you. So I'd like to begin by briefly discussing what exactly QUERI is. That's one of the research groups I belong to here in LA. QUERI stands for Quality Enhancement Research Initiative. It's basically a group of researchers scattered around the country, which I'll go through in a minute, and they focus on issues that are that acutely affect U.S. veterans. The overall mission of QUERI is to enhance the quality and outcomes of VA healthcare by implementing clinical research findings into routine practice. We do that by integrating research, clinical, operational, and policy expertise to improve policy. We do that by targeting high-priority diseases, as I just mentioned, and health delivery issues for veterans. We also evaluate interventions to encourage best practices in the VA healthcare system. And finally, we also work to identify knowledge gaps and create new data to inform VA policy. Queries are scattered across the country, and as I mentioned, they are targeted to healthcare issues that affect veterans very acutely. I belong to QUERI HIV-Hepatitis. We have 3 branches of QUERI HIV. We have our LA branch. We have a Bedford branch in Bedford, Massachusetts, and we also have a group of researchers in Palo Alto. As you can see, there are queries across the country. We have spinal cord injury in Seattle and in Chicago. I'm also affiliated with them. We have heart disease query in Seattle. You can see you can see across this map that queries are research groups, and they work, as I mentioned, on specific veteran-centric issues. As I mentioned, I'm with QUERI HIV-Hepatitis. Our main mission is to improve the identification and patient care of veterans infected with HIV and hepatitis C viruses through implementation of evidence-based findings. Our 3 main research areas are better disease identification, improving linkage, retention, and adherence to care, as well as reorganizing care for improved coordination and value. So I'd like to briefly talk a little bit about HIV. You know, about 20 or 30 years ago, HIV was on everyone's radar screen. It was always reported in the news. People were having benefits and things of that nature. Everyone, you know, HIV was a main topic of conversation. That's changed in the last, you know, decade or so. But that really shouldn't be the case, because HIV continues to be a very big problem both in the United States as well as internationally. And to that point, we recently, the CDC released information that, that they were underestimating the level of HIV infection in the United States. They were underreporting current HIV levels by about a factor of 40%. What that means is that to this day, we are identifying about 50,000 new HIV-infected individuals annually in the United States. So that's still a big problem. We also know that, that approximately 60% of all Americans have never once been tested for HIV. We do know that HIV is treatable now if detected early, but we also know that late treatment or late diagnosis of HIV increases one's risk for HIV mortality. In 2010, the White House released a national HIV AIDS strategy. These are goals that the White House sets for national policy in regard to HIV AIDS. There were 3 domains as part of this strategy. The first was to reduce new HIV infections, operationalized by lowering the annual number of new infections by 25%, reducing HIV transmissions by 30%, and increasing the percentage of people with HIV who know their status. The second goal is to increase access to care, operationalized by increasing the percentage of newly diagnosed patients linked to care. And the third goal is to reduce HIV-related health disparities, operationalized by improving access to prevention and care services for all Americans. So for those federal researchers who work on HIV and AIDS, this is basically, these are our marching orders. And so we integrate this into our work every day at QUERI HIV. So now specific, what about HIV in the VA? We know that the VA is the largest provider of HIV care in the world. The VA cares for upwards of 20,000 HIV positive patients on an annual basis. And we also know that VA patients generally are at greater risk of HIV, but they continue to have low testing numbers. Approximately 8 out of 10 veterans have never been tested for HIV, even though we know that generally that they are at higher risk. So now turning to recent statistics on homelessness. Homelessness obviously is still a big problem in our country, will probably be a big problem for years to come. Current statistics are approximately 3.5 million people are homeless on any given night nationwide. Unfortunately, LA County leads the nation in homelessness. Estimates are upwards of 80,000 people are homeless on any given night on the streets of Los Angeles County. And we also know that approximately 40% of those 80,000 people are veterans. So this is a big problem for veterans. It's a big problem for society, but it also impacts veterans very acutely. In terms of HIV risk among the homeless, we know that the numbers are very high for this subpopulation of people. We know that because there have been a variety of sero studies taken of homeless individuals throughout the country. As we can see on this slide, we look at a variety of locations across the country and we look at the seroprevalence and we see that it's you know, in some places it's off the chart. Florida, we have 5% seroprevalence. New York, almost 4%. Houston, 4%. San Francisco, 9%. Almost 1 out of every 10 people in San Francisco, 1 out of every 10 homeless individuals in San Francisco is homeless. So these are very striking numbers, and it's just more evidence that we know that HIV impacts homeless individuals very acutely. So then the question to ask is, if we know that the homeless are at much higher risk for contracting HIV, then why do they continue to have low rates of HIV testing? And we know that there are large barriers to testing among the homeless. One of those barriers is that the conventional way of HIV testing, which is venipuncture-based testing, requires 2 appointments, the first to draw the blood and the second to provide someone with his or her results, because the blood has to be shipped to a lab, analyzed, and then the results are provided. That's a 2-step process, and with homeless individuals, that becomes very problematic for obvious reasons. Another barrier is that patients and providers do not prioritize issues like HIV prevention. We know among the homeless that obviously transportation issues are a big problem, getting to and from a clinic to get tested, getting to and from a hospital, and then just most basically, the homeless have competing priorities that obviously are going to take precedence, those being getting food, safety, and shelter. So HIV, of course, is going to be weighed down on that list. Recently, in 2009, the Centers for Disease Control and then subsequently the VA released new HIV testing recommendations where they now recommend routine HIV testing for anyone, not just homeless people, not just people at risk, but anyone in the United States between the ages of 13 and 64 once per lifetime. We also know that HIV testing is cost effective even at levels of low prevalence, and we also know that, or we also should consider the use of novel approaches when considering the adoption of routine testing, one of those novel approaches being the rapid test, which I will speak about right now. This is a device that's been around for about 7 or so years. It's an FDA-approved device. It does have advantages over current venipuncture-based testing methods in that it is a non-invasive test. It's an oral swab test. No blood needs to be drawn. It is statistically equivalent to blood-based venipuncture testing, and a big advantage over venipuncture testing, as I mentioned previously, is that as opposed to a two-step process, blood draw and then subsequent visit for results, you can give someone their results with the use of the rapid test in approximately 20 minutes. So big advantages over venipuncture-based methods, and an ideal approach to testing among the homeless. So that brings us to project number 1. So with all these things in mind, the thinking was, well, why don't we do something about the lack of testing among homeless veterans in LA County? So we applied for what's called a Rapid Response Project. That's a VA terminology for basically a quick turnaround grant, where they give us a small pot of money to come up with a pilot effort for a proof of concept to see if something like this could fly. So that's what we did. We applied for the grant, we got it, and in collaboration with LA County Department of Health, we accessed 9 shelters in LA County. We were only able to approach veterans. We approached approximately 3,000 veterans. We approached 3,000 people, and 136 of those were eligible. We were asking them, are you a veteran or not? And if we could only test them if they were veterans. So that's why such a low number were eligible. Out of those 136, 97 of those accepted the HIV rapid test. So what were our findings? We found that among those people that we did test, that the rate of new incidents for this group of people was almost 2%, very high HIV infection rates among this subpopulation of people. We also did qualitative research and found that there was high acceptance among this group of people for testing. They were very accepting of the rapid test. They really didn't have issues with it. But one striking finding is that almost 80% of those people reported that their personal chances of getting infected with HIV is either none or low. So we know that there's kind of a disconnect here. We know that they're at much higher risk. They personally don't think that they are at much higher risk, so that presents a big problem for the continued spread of the HIV epidemic. So then we took these, so in terms of implications for these findings, rapid testing is obviously feasible and was acceptable at the shelters we approached here in LA County. We found that the collaboration with non-federal government agencies was a practical one, and that policymakers should consider rapid testing when implementing routine testing in shelter settings. So then there was a problem, though, and I did allude to that problem in a few slides ago. We approached about 3,000 people, but we had to turn away the vast majority of those people because this was a VA-funded effort, and we are only precluded from outreaching to veterans and to link veterans to care. We weren't able to test non-veterans because they're not veterans. So we thought this was a big problem. So in order to overcome this problem, we had to apply for non-VA funding to do that. So I wanted to thank Gilead Sciences because they're the people that we targeted for funding, and that was our funding agency. So this brings us to project number 2, which was a larger effort. This was implementing HIV testing in LA area homeless shelters. As I mentioned, it was an external grant through UCLA and Gilead Sciences. It was a dual award. We got a $150,000 initial award, and they were so happy with the progress of the project that they gave us a $66,000 supplemental award a year into the project. The participating agencies were the VA, LAHSA, which is the LA Homeless Services Agency, LA County Department of Public Health, and LA City AIDS Coordinator's Office. A little bit about LAHSA. A lot of you might not, here in LA, might not know what LAHSA, might not have even ever heard of LAHSA. LAHSA, the Los Angeles Homeless Services Agency, is an independent unit of LA County government. They're responsible for addressing homelessness here regionally, and they are the umbrella funding agency for most homeless services in LA County. Through a series of meetings with LAHSA, we were able to gain access to the homeless shelters in which we provided the LA-based HIV testing. In terms of our results, we tested over 800 people, not just veterans. We opened it up to everyone. During our testing period, we identified 7 HIV-positive individuals. We linked 6 out of 7 to long-term care, either to LA County medical care, or if they were veterans, to VA care. One person refused to be linked because they had private medical insurance. So we are very happy with the project, and we are also very happy that this has now become the new standard of care for LA County. LA County is now doing rapid testing in homeless shelters in and throughout the county. In terms of future homeless outreach efforts, they aren't going to be HIV-based, but there's still some big problems out there. Oh, well, actually, there is this one that I forgot about. This is the what we're trying to do with this project is we're trying to widen the scope of our LA-based efforts and move this to the Bay Area here in California. It's an expansion of our recent LA efforts. It's in collaboration with the VA and Stanford University. We have memoranda of understanding signed with San Mateo, Santa Clara, and Santa Cruz counties. We're going to be shooting for externally funded grant money through either Gilead Sciences again or QUERI. The main difference with this project is the way that this one is going to work, if it does work, we hope it does, is that we have coordinated with Stanford University Medical Center to allow medical students to go out to the homeless shelters throughout the counties in the Bay Area for class credit. So that's a new novel approach to this, and we hope that it'll work. We're trying to move that forward as we speak. Also, recently, this article came out in late April, which I thought was, I've never thought about this before, and I don't know why. It makes perfect sense, but I've never seen this reported. And this was a Time magazine article that showed that that 45% of homeless men had a previous traumatic brain injury. And so when I read that, I did a little research, and I found that there's not all that much at all literature on this topic. But I did find 2 studies in, I believe it was Toronto, that did look at this and found that indeed this is the case, that in these small subpopulations that these 2 researchers looked at, that it was the case that there's a large proportion of homeless people that have had previous traumatic brain injury. And traumatic brain injury is one QUERI center. I forget, I think they're based in Minneapolis. So this is one area of research that I would be very interested in pursuing. I did have an initial call with the chief of the TBI QUERI, and we did discuss this, and so we're trying to slowly move this forward, and hopefully we can gain some traction, because as you can well imagine, with the conflicts that we're currently engaged in overseas, a large proportion of veterans that are coming home are going to have traumatic brain injuries, and it's only a matter of time before they filter through the system. And you know, if this data is any indication, maybe 5 or so years down the road, they're eventually going to a large proportion of them might end up homeless. So you know, we're hoping that this could lead us in a different direction, which we think would be an important one for veterans. We also are engaged in homeless outreach, linkage to care effort in Mississippi. A doctor in Jackson, Mississippi caught wind of our work and applied for funding, so I am co-PI on this project. It's basically doing rapid testing in homeless shelters in Jackson, Mississippi. They've adopted our approach. The start date was February 2014, and that's plugging along, and we're very happy about this effort as well. And that's it. Those are some of the homeless outreach efforts that I've been involved in, and I'm happy to open it up for questions or comments, what have you.
We're trying to open some of the messages online, so give us a few minutes of silence. Thank you.
So everyone can speak now.
Everyone should be able to speak and ask questions.
Brian, Mitt, and Henry, thank you very much for presenting. Those of you who are now unmuted and maybe on a cell phone, if you could mute yourself at your end so that we don't pick up any background noise. Henry, thanks again for presenting as our inaugural speaker. I wonder if you could talk a little bit about what you've learned about collaborations within the LA area between the various policy and practice and research groups for doing this sort of work.
Yeah, thanks, Brian. That's a great question. You know, the main thing, we learned a few main things. One of the main things we learned is don't underestimate the amount of time it will take to get county government or, you know, federal and county government on board. It took a lot longer than I thought it would, and it wasn't because people weren't willing to join, or it wasn't that they weren't willing to listen or come to the table. A lot of the delay basically was just scheduling. So I mean, and you'd think that that's such a small thing, like, wow, scheduling, but that's a big deal because, you know, you're chomping at the bit to get something started, and you have the grant money, and you're ready to go, and you know, everyone's in place, and you know, we've encountered this in other projects as well. So I no longer underestimate the amount of time it takes just to get the momentum going, to get an initiative started. But so that would be one lesson learned. If you're going to engage in any type of implementation initiative, give yourself plenty of time to get the ball rolling. Another thing that we learned is, you know, you have to, if you're asking people, to, and you know, this is something that I'm sure a lot of people on the phone are well aware of, but if you're trying to get someone to adopt something that they haven't tried before, you have to make it attractive to them to want to do it, because you're basically asking them to do extra work. The county was I'm sure very happy to not do anything, to not even hear from me. They would have just chugged along and done the great work that they do, and everyone would have been fine. But it was kind of the persistence, me kind of, you know, knocking on the doors and picking up the phone, and you have to be very persistent at this stuff. And again, it's not because they don't want to, it's because they're busy, it's because, you know, they already have their way of doing things. So when you're approaching them, make sure that your package is as attractive to them as possible, and try to make sure that you have it ironed out enough so that there's not a lot of bugs that they have to wade through to get this thing up and rolling. You want to make your package as streamlined as possible so that they can just take it, adopt it, and see if it works or not.
Are you asking, can you ask for now if you've got a chunk, you've got a lot now?
We could barely hear you. Can you please talk closer to the phone and repeat your question, please? Hello?
I'm not sure if that was a question that was directed at Henry or if someone is not on mute and was engaged in a background conversation. Was that a question for Henry? Okay, let's open up to the broader group. Other questions or comments from others on the presentation?
Yeah,
There are some people that aren't unmuted.
I think those are people who are not.
Yeah, Artur, Ibrahim, I'm not sure if you had to enter an audio PIN in order to have the option of being unmuted. I also don't know if you can see the text box. So there is a question option within the software system. But let's give it another couple of minutes. Other questions or comments from other participants?
You can
Right here?
There's one.
Okay.
Henry, I don't necessarily mean to put you on the spot, although obviously I am. Are there some thoughts that you could share from your QUERI experience within the VA, both within HIV/AIDS QUERI as well as spinal cord injury, regarding the broader topic of partnership research and how to work with operations leaders, clinicians, administrative leaders in designing and conducting implementation studies?
Yeah, sure. So I'm currently co-leading a project with, I'll use this as an example. I'm co-leading a project with Hildy Hagedorn from QUERI Substance Use Disorder Clinic. Substance Use Disorders, I'm sorry. And you know, the same basic principle applies. You know, people are willing to collaborate if it matters to them, if they can see the importance of what it is you're trying to do. So when I approached Hildy, I'm using Hildy as an example, when I approached Hildy about adopting HIV testing in substance use disorder clinics, I had to make the case for it, and then we had to run it up both our leadership's food chain. We had to, you know, tell them what the thinking was behind that, what the rationale was, and how we were going to make, you know, what our vision was for it, and how we were going to make it happen. The same thing holds true for other sponsored research when we're trying to collaborate with VACO, for example, and talk about busy. You know, you think that people in LA County or LA City are busy. VACO is just as busy. So trying to get VACO on board to you know, collaborate on these types of things, they're all for it. For the most part, they're all for it because that's what our mission is. But it's trying to get someone's ear bent enough to talk about what it is that you're trying to do, how they can help, and what resources that you need from them. So, you know, the basic lessons apply both cross-QUERI and cross-governmental agencies, I think.
Great, thanks. And again, let's open up to others, other questions or comments, and we don't know how many of you are still muted. Okay, so Henry, the next question on my list is what suggestions you would have to the various stakeholders, and especially I think, well, not just to researchers, but you know, to our policy practice colleagues in the local area. What suggestions to facilitate this sort of work? So as you know, a major goal of our March symposium was to you know, begin some networking or to enhance and strengthen you know, some of the existing networking, but to try to accelerate and expand the volume of projects of this sort. Are there things that you've learned, again, either from your LA County work or and/or from QUERI that lead to some specific suggestions and activities for us as leaders? Yes,
I mean, we did. I think we might have touched on that at one of our briefing calls after the symposium, Brian. But to reiterate, I think some of our thinking on that score, you know, based on our final set of discussions at the end of the symposium in March, you know, and I'm going to repeat this because I know I repeated it on our briefing call. Anything that happens you know, in terms of moving forward within the county, you need the county on board. You need the county and the city on board. So we need, if we want to adopt some of these, you know, healthcare initiatives, they need to be first and foremost at the table. And I know that they're willing to be at the table because they mentioned that at the symposium. So I think for a recommendation, it would basically be getting on the phone or getting on email and saying, look, you know, we have something that we think is important for the VA, if it's going to be a VA-focused thing, and we would like the county to participate, county and city to participate. Can we please try to figure out a time where we could all come together and meet and, you know, for a couple of hours and discuss our ideas and see how they would mesh with how you want to move forward. But remember that at the symposium, the county has their own list of priorities that they want to see move forward. So I think maybe the best approach would be to look at what the county's priorities are, see what, if any, of those priorities mesh with VA-centric priorities, and then come to the table and see if there are ways that we could collaboratively move forward.
And is this sort of a one-by-one, project-by-project activity, or there's some centralized groups, leadership groups, or you know, communication channels that exist that you would suggest we use? And, you know, maybe the way to think about it is from the perspective of an individual investigator. How should he or she proceed?
Yeah, so if you're going to go that route, then the individual, like, you know, me, I would, you know, the individual investigator, I was interested in moving an HIV portfolio forward. And so what I did was I called the Department of Public Health, Office of HIV, as well as the City Office of HIV/AIDS, and just started kind of knocking on doors. So if that's the route that someone wants to take, it's as simple as finding out who the players at the county and city are, and start knocking on their doors and telling them what you're all about, who you are. Can I get a meeting with you? Can I get a half hour of your time? Come very prepared with what it is that you want to talk about, and then you know, try to get them engaged in moving forward. Now, if we want to do this in kind of with a more broad scope, then we would have to think about what agency would most represent that research agenda that we want to push forward. So if it's, you know, say influenza, then we would contact infectious disease. If it was cancer research, you know, what have you. If it's homelessness, we know who to contact. It's basically what is the agenda that and issue that we want to move forward, and then identify the people at, you know, at the county that can help us move that forward.
So I'm curious as to whether others on the phone, ideally those who are not muted, have other related experiences with the county and could add to this discussion, you know, pass along your experience and your recommendations. Including those who are with you at UCLA, Henry. I'm sorry.
There's a question online. This is from Lucia Williams. Do you collaborate with community input?
We certainly do. You know, using the Homeless Outreach Project as an example, we did not do anything without LAHSA representation, without homeless shelter representation. We remember that just because LAHSA gave us the green light to go into these 9 shelters didn't mean that we didn't still have to go to those shelters and advocate for what it is we were doing. They had every right, you know, they had every right at each of those shelters to say, no, we don't want you here. LAHSA, you know, can only say, yes, you can go contact them. We still had to get each of those, I should have mentioned that in the talk, we still had to get each of those 9 shelters on board. So it wasn't just that LAHSA said, yes, go ahead. We had to go and make our case at each of the shelters, and those shelters represent their clientele. So yes, we, at every step of the process, we had community buy-in before we tested one person. And that's a great question, by the way.
Hi, this is Plessida Williams. I finally figured out how I can talk on the phone. Thank you for that answer. But what I was speaking about is people in the community that live in the community, you said they were at every a step of the process. Did you sit down with them when you came up with the ideal and then formulate and progress through that? Not after you've done it and went to them and said, can you help us show us to do this? I'm talking about from the beginning until where you are now.
Well, in terms of like an individual community spokespeople, no. What we did was we went through the LA Homeless Services Agency, who did have community representatives as part of the discussion group, and we used that as our initial way forward, and then we engaged with shelter representation.
Okay, thank you.
Sure.
There's another question on the line. This is from Dr. Jeffrey Gunzenhauser. What characteristics qualify the described effort as a scientific translation or implementation science challenge, as opposed to simply being an effort to partner with others to pursue specific goals?
I don't know that I can. Qualify the difference between the two. So let's see. What characteristics qualify this as a scientific translation or implementation challenge? Well, I don't know the best way to answer that. I mean, what you're saying at the Dr. Gunzenheimer, what you're saying if I'm reading it correctly, what you're saying at the bottom of your statement is an effort. It was an effort to partner with others to pursue specific goals, but that's part of implementation research. Part of implementation research is it's not implementation research. Should not be that complex. We try to make things as easy as possible. Part of the challenge of implementing an initiative is getting partnership, and without that partnership, you're not going to move forward. If I didn't have county partnership, there's no way in hell that I would have been able to gain access to any of those shelters. So in that respect, it is an implementation challenge to get people on board. Is it, this rigorous implementation science, agenda? No, it's getting someone on board. It's moving your agenda forward. That is all implementation. So, did we adopt rigorous implementation science principles? No, but we sure used implementation science theory to figure out that we needed local champions, which is kind of the Rogers diffusion of innovation stuff. And you need local champions in order to adopt this once you remove yourself from the picture, which is what we did, so that LA County did end up adopting this as a standard of care, because we did put in place those people who were champions of this initiative after the fact. So I hope that that's an answer to your question.
Yeah, Henry, this is Brian. I think I would interpret the question, in addition to the thoughts that you passed along, is touching on distinctions between quality improvement work and quality improvement research or implementation science, and questions such as are there generalizable knowledge contributions that will emerge from this? Are you planning on analyzing data and writing up your experience in a way that would contribute to generalizable scientific knowledge in addition to achieving the policy practice goals of the project?
Yeah, we've written up our findings, our qualitative findings from this project, and are in the process of having it peer reviewed. I know it's in a journal right now. I'm not sure. It's a journal for the healthcare for the underserved. I'm not sure which journal it's in. But yeah, we definitely do that with every one of our projects. We make sure that we as best we can generalize what knowledge that we did find to the larger community who are interested in trying to adopt some of the approaches that we've taken.
Yeah, so I think again that that's my interpretation of the question. I think it's an issue for all of us doing this sort of work. Many of these represent hybrid projects that are attempting to pursue simultaneously local improvements in a way that any of these agencies or stakeholder groups would wish to pursue for the purpose of improving care, but we're also trying to contribute back to the science of implementation, and again, contribute generalizable knowledge. And it sounds like you have been pursuing both of those simultaneously.
There is an audio pin that you should have received or that you should have available. If you are trying to answer a question via the phone, you can do just enter that code and you'll be able to. Otherwise, you can also answer the question via the GoToWebinar.
I know, Henry, you've answered all of my questions, so that I won't pass any others along. We may be able to wrap up a little bit early, but let's give it another few minutes in case there are any questions submitted online or via phone. We are getting a little bit of background noise. I'm not sure if it's someone typing or other.
Keyboard. I think someone. Maybe that's a question or something unrelated, but she can mute here.
And so as we're giving a couple more minutes in case there is someone submitting a question by typing, a couple of comments, one of which is we would like you to complete an evaluation survey. You'll see a link via email. And we'd also like to remind you that there will be additional talks. We haven't yet confirmed the August speaker or title, but watch for email. And if you have suggestions or requests for additional presenters, we'd love to hear them. And we also are in the process of planning a Part Day symposium as a follow-up to the March gathering during the fall. Date is still to be determined.
So I had a pretty good sense of what the program was like.